Hello everyone, my name is Shweta Santosh Shelar. I am a student of second year B.Pharmacy from Shivajirao S. Jondhale College of Pharmacy, Assangaon. Today I am going to present a topic from subject medicinal chemistry first, that is narcotic and non-narcotic analgesics, under the guidance of Dr. Nitin C. Mohire sir as a principal and professor of our college. First, we will see what is analgesics. Analgesics is any member of the group of drugs used to achieve analgesia or relief from pain. There is a major classes of analgesic drugs include opioids, non-steroidal anti-inflammatory drugs, acetaminophen, flupirtine, and ziconotide. Then we will see narcotic analgesics or opioids. Narcotic analgesics are drugs that relieve pain by binding to opioid receptor which are present in the central and peripheral nervous system, can cause numbness and induce a state of unconsciousness. They are classified into natural compounds. Examples are morphine, codeine, papaverine. Second, semi-synthetic examples are diacetyl morphine, benzyl morphine, and ethyl morphine. Then synthetic derivatives, examples are fentanyl, pethidine, methadone, tramadol, etc. Then loperamide. Loperamide is an opioid that does not enter the brain and therefore lacks analgesic activity. Mechanism of action of narcotic analgesics is all opioids receptor are G protein coupled receptors and inhibit adenylate cyclase. They are also involved in postsynaptic hyperpolarization, increasing K plus efflux, reducing presynaptic Ca++ influx, thus inhibit neuronal activity. Then we will see what is opioid receptors. Opioid receptors are linked through G proteins to inhibition of adenylate cyclase. They also facilitate opening of potassium channels and inhibit opening of calcium channels. There are four types: microreceptor, sigma receptor, delta receptor, and K receptor. Microreceptors are thought to be responsible for most of the analgesic effect of opioids and for some major unwanted effects. Most of the analgesics opioids are microreceptor agonists. Microreceptors are two types. Mu1 are located outside spinal cord. They are responsible for central interpretation of pain. Mu micro 2 that is located throughout CNS, responsible for respiratory depression, spinal analgesia, physical dependence, and euphoria. Then K receptor contribute to analgesia at the spinal level and may elicit sedation and dysphoria but produce relatively few unwanted effects and do not contribute to dependence. Delta receptors are probably more important in the periphery and may also contribute to analgesia. Sigma receptors are not true but receptor and it is unclear that what delta is actually responsible for but may regulate mu receptor activity. Agonist and antagonist are opiates vary not only in their receptor specificity but also in their efficacy at the different types of receptor. Thus, some agents act as agonist on one type of receptor and antagonist or partial agonist at another, producing a very complicated pharmacological picture. Example of agonist are morphine and morphine is the major analgesic drug contained in crude opium and is the phototype strong agonist. Then example methadone. Methadone is synthetic orally effective opiate that is approximately equal in potency to morphine but induces less euphoria and has somewhat longer duration of action. Then last example is fentanyl. Fentanyl and subtanyl are highly potent phenylpiperidine derivative with action similar to those of morphine but with a more rapid onset and shorter duration of action, particularly subtanyl. Partial agonist and mixed agonist antagonist. These drugs, naloxone and pentoxicin, combine a degree of agonist and antagonist activity on different receptors. There are examples are naloxone. Naloxone is closely related in structure to morphine and has a more complicated action. Then pentazocine is a mixed agonist antagonist with analgesic properties similar to those of morphine. Buprenorphine is a partial agonist on microreceptor. It is less liable to cause dysphoria than pentazocine but more liable to cause respiratory depression. Antagonists. These drugs produce very little effect when given on their own but block the effects of opiates. The most important examples are Naloxone and Naltrexone. Naloxone was the first pure opioid antagonist with affinity for all three opioid receptors. Then naltrexone. Naltrexone is very similar to naloxone but with the advantage of much longer duration of action. Here the chart of narcotic drugs, their uses and adverse effects. Non-narcotic analgesics example are NSAIDs, acetaminophen or PCM, fluoxetine, Ziconotide. Acetaminophen are popular staple alternate to aspirin. They are domestic analgesic used in both adults and children. Over-the-counter drug, rapidly absorbed, mostly metabolized by conjugation and excreted by kidney. Very less adverse effect in their therapeutic dose. Their uses are useful in mild to moderate pain like headache, pyrexia, myalgia, etc. Fluoxetine. Fluoxetine is a centrally acting non-opioid analgesic that is available in number of European countries for the treatment of variety of pain states. Then Ziconotide. Ziconotide is a non-narcotic pain reliever that is used to treat severe chronic pain in people who cannot use or do not respond to standard pain relieving medications. There are reference videos that is used to prepare these videos. Thankful to our President Honorable Dr. Shivajirao Jondhale Sir, Secretary Honorable Dr. Geeta Khare Ma'am and Principal Dr. Nitin C. Mohire Sir for encouragement and guidance for efficient use of social media to spread knowledge about informative video. Please like and subscribe and comment our YouTube channel. Thank you.